Lectures. This is a complete change of topic, and I've been asked to introduce the title in a slightly different way, so that's exactly what I'll do. So the second Doctoral Inaugural speaker is Dr. Prahap Kingala, and I'll let him introduce his own career, which is probably not easier than me doing it, and you're going to talk about heart failure. Is that enough?
That's perfect.
You don't want me to say what's actually the real title, because I think we'll leave it there. So your Doctoral Inaugural Lecture, please. Floor's yours.
Right, good evening everyone. It's a real pleasure to be back here in Leicester sharing my research work with you on this platform. I'm a consultant cardiologist by trade, but I trained in Leicester for my clinical training as well as my research at the Cardiovascular Sciences building. It's especially nice to see so many friends and colleagues in the audience. So the title of my talk is HFrEF, HFpEF, what the F? Now the reason I've chosen this title is because that's the reaction I got from lots of colleagues and various people in the medical fraternity at the time of my research. There was a lot of uncertainty about HFpEF, or should I say heart failure with preserved ejection fraction. So quite often I'd actually get asked, does HFpEF really exist? Isn't it all part of the same heart failure syndrome? Isn't it called diastolic heart failure? Is it not HFnEF? Isn't it just a mishmash of comorbidities in those patients with normal left ventricular systolic function? So I hope to address all of these questions as well as expand upon the knowledge base based on my own research. So I'm going to give you a bit of a background overview about heart failure in general. These are some of the headline figures. There are currently just under 1 million people living in the UK with heart failure. The majority of these patients are elderly and have multiple comorbidities. And if you think about it, for a singular medical condition alone, heart failure accounts for nearly 2% of the total NHS budget. Heart failure is the most common cause of hospitalisation in patients above 65 years of age. When these patients come in, they tend to stay in hospital for a long period of time. And when they do come in, nearly 1 in 10 of them die during that admission. And mortality starts approaching just under 50% at 5 years. So at the beginning of my research, there was a lot of conjecture. Certainly there was no consensus as to whether HFpEF existed, whether it was part of the same syndrome, along with heart failure with reduced ejection fraction, or whether it was separate. The evidence that it was part of the same syndrome came from initial epidemiological studies, which showed a unimodal pattern of left ventricular ejection fraction, which is a marker of your systolic function. And if you were to assess these patients by the bedside, they had similar clinical features, so it's hard to distinguish between both. And actually, outcomes, if you look at the outcomes, are largely similar, albeit HFpEF slightly better. And from longitudinal data, we know that there's a transition of a subset of these patients from HFpEF to HFrEF, HFrEF to HFpEF. So we thought, okay, it's all part of the same syndrome. Heart failure exists as a continuum as one. But using more contemporary clinical trial data, the pattern that's emerged is there is a bimodal, or dare I say, it's a trimodal pattern of left ventricular ejection fraction. So on the one side, you have patients with ejection fraction less than 40%. So those are your heart failure with reduced ejection fraction. And recently, data has emerged where there's a grey area where you have patients with ejection fractions between 40 and 50%. So that's your second peak. And then there's a third peak, your HFpEF patients, where ejection fraction is more than 50%. And certainly these HFpEF patients appear to have a different epidemiological profile. They quite often tend to be older, have a history of hypertension, ladies with multiple comorbidities including obesity, diabetes, renal impairment and lung disease. And when you were to image these patients with the traditional echocardiography, these are the typical characteristics you see with someone with what we know as systolic heart failure, so your heart failure with reduced ejection fraction. So for those of you not familiar with echo, black is blood in these images, white is anything solid, so either muscle or heart valves. So this patient has heart failure with reduced ejection fraction. I think hopefully all of you will agree that contractile function here is reduced. The heart's not pumping very well. And the cavity of the left ventricle is big. And the heart muscle is quite thin. Either it's because it's being damaged following a heart attack, or they've got a heart muscle disorder. Now, you contrast that to a patient with what we call HFpEF. These patients have an enlarged left atrium. The contractile function is quite good, the heart's pumping well. And these patients have left ventricular hypertrophy, so we thought, hang on a minute, the problem is not systole, it's got to be diastole, because your heart has a cardiac cycle, systole and diastole. So these patients were termed as having diastolic heart failure. And these are data from pressure volume curves where you put a catheter in the heart. So your traditional systolic heart failure patients, you expose them to more volume. That chamber, the left ventricle is able to adapt and fill with blood. And it does it by dropping its pressure within that chamber. In contrast, the diastolic heart failure patients, you give it the same amount of volume. They've got thick-walled heart muscle, and thick-walled heart muscle predisposes you to scar tissue, which means your heart's not able to relax in the first place. So what it does, the pressure within that chamber increases. But, and there's a big but, diastolic dysfunction does not equate to diastolic heart failure, because in a third of healthy individuals, controls, diastolic dysfunction is present in those cases. In a third of these so-called HFpEF patients, diastolic dysfunction is absent. And actually, diastolic dysfunction is present in all of the cases of heart failure with reduced ejection fraction. So that phrase was disbanded, and it changed to heart failure with normal ejection fraction. Now, in these patients, whilst overall systolic function is preserved, so the overall pumping function of the heart is normal, there are subtle systolic abnormalities in long axis function and circumferential function. So that terminology now has changed to what we now know is heart failure with preserved ejection fraction. But this is perhaps one of the most important slides in my talk. What I want to do is show you that actually it's not just comorbidities. Look, it's well recognized that HFpEF patients have far greater degree of comorbidities compared to systolic heart failure patients. These are data from general cardiovascular studies, and something happens to these patients, They've got the same degree of comorbidities as HFpEF, but suddenly, in green, are the HFpEF patients. So something happens to these patients where the mortality suddenly shoots up, and so does heart failure hospitalization. So it's not just comorbidities. And it's been postulated that these comorbidities induce inflammation and drive fibrosis. For those flow volume curves that I showed you before, when you expose a patient to increased volume, the response is not uniform, so it suggests there's some heterogeneity in pathophysiology, and there's a wide range of mechanisms that have been postulated. And to add to that, from my very own research, we looked at proenkephalin, which is an endogenous opioid biomarker, and it's closely related to renal function. What we showed was that in a large multi-center study, proenkephalin levels are significantly elevated compared to control populations. And they're closely related to markers of diastolic dysfunction. And the higher the level that you have, the worse the outcome. We also looked at trimethylamine N oxide, which is an active gut metabolite, closely related to the Western diet. And again, we found these levels are elevated in HFpEF compared to controls. And again, the higher the levels that you have, the worse the outcomes. We also looked at diabetics versus non-diabetics. So if you're type 2 diabetic with HFpEF, we noticed some subtle abnormalities. There was a lot more left ventricular concentric remodeling. Left atrial size was different, was lower. And type 2 diabetics were associated with a plethora of biomarkers that were related to systemic inflammation. So again, suggesting that different mechanisms at play and different potential therapeutic targets. But perhaps the greatest evidence that HFrEF and HFpEF are separate comes from clinical trial data. There's a fantastic evidence base for patients with systolic heart failure and HFrEF. You give these patients ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, or indeed recently sacubitril valsartan, and they drastically reduce mortality. But you give the HFpEF patients the same treatments, and there is no shift in mortality. Which then poses the question, why have treatments failed? And from my literature review, I noted there have actually been 5 sets of international guidelines published as to for diagnosis of heart failure with preserved ejection fraction. And actually each different set of guidelines has different diagnostic thresholds, so perhaps it's not surprising that treatment trials have failed. So we're left in a scenario right now where no treatment is effectively shown to reduce mortality in HFpEF. And this is how we currently diagnose HFpEF. So first, you need to have signs and symptoms of heart failure. So you need to be breathless, have edema, etc. And you need to have a left ventricular ejection fraction greater than or equal to 50%. And you need to have elevated natriuretic peptides. And you need to have one surrogate measure of diastolic dysfunction. That can be either by putting a catheter in the heart and show elevated pressures in those chambers, or you need to have some evidence of structural heart disease, so an enlarged left atrium, or left ventricular hypertrophy, or echocardiographic measures of diastolic dysfunction. And another reason why I think the treatments have failed is because of our over-reliance on echo. Okay? Echo is fantastic, but it is the gatekeeper for clinical trial entry, but it does have inherent limitations. From the heart failure population alone, we know that in a third of cases, there is suboptimal endocardial border definition. So you can't actually reliably measure the left ventricular ejection fraction in the first place. And the only reason I've left this bit here is to show that I'm not an echo skeptic. In fact, I'm extremely passionate about echo, but I'm a co-author of the national guidelines for echo. And as part of my literature review, I compared the various imaging modalities to see whether they'd be suitable for HFpEF. And what's without doubt is that cardiac MRI is the gold standard for volumetric and functional analysis of the left ventricle, right ventricle, and left atrium, as well as for left ventricular mass measurements. And it has inherent properties that enable tissue characterization more so than echo. And actually, the number of patients who need to recruit into clinical trials with cardiac MRI is far less. As an example, if you wanted to detect a 3% difference in ejection fraction, you need to recruit over 100 patients with echo. That figure dwindles drastically to about 15 patients with cardiac MRI. So on this basis, we conceived the following study, which is my research study called the Diamond HFpEF study. And it stands for Developing Imaging and Plasma Biomarkers and Describing HFpEF. The overarching aim of my study was to utilize cardiac MRI and to a certain degree plasma to better characterize these patients and to provide mechanistic insights into pathophysiology, as well as develop novel biomarkers and assess their relation to clinical outcomes. So, the patient would come in typically for a study visit that lasted 3 to 4 hours, where they will undergo comprehensive clinical evaluation. We took blood and stored some of that blood for plasma analysis at a later stage. They also underwent echocardiography, cardiac MRI, during the same setting. And they completed a Minnesota Living with Heart Failure questionnaire. And we followed these patients up for the composite endpoint of death and or rehospitalization with heart failure. We defined HFpEF as clinical or radiographic evidence of heart failure and a left ventricular ejection fraction more than 50% on echo. We excluded patients with a prior myocardial infarction in the last 6 months, any suspected cardiomyopathy or constrictive pericarditis or significant valve, lung or renal disease. And then we compared them to age and sex matched HFrEF and healthy controls. So the first part of my research was to see, hang on, does cardiac MRI add anything clinically to standard evaluation? So we looked at patients undergoing echo and cardiac MRI on the same day, and we identified that cardiac MRI itself identifies in a significant minority, so well over a quarter of subjects, new, previously undiagnosed, clinically relevant pathologies, each with their different treatment targets. And these included myocardial infarction, coronary ischemia, microvascular dysfunction, hypertrophic cardiomyopathy, and constrictive pericarditis. So all of these conditions can alternatively explain why these patients supposedly have HFpEF. But actually, when you group these disorders, these new findings together, they single-handedly predicted adverse outcomes at just over 2-year follow-up. So we excluded these new pathologies as such, and we looked at a purer cohort of HFpEF. It's been postulated that fibrosis is the main driver for HFpEF, so we undertook both qualitative and quantitative analysis for focal and diffuse fibrosis. So on the left panel here are late gadolinium enhancement images for cardiac MRI. So for these, we run a set of sequences where we make or we null a signal from normal heart muscle to make it look black, so the areas of abnormality show up as white. And it's important to identify focal fibrosis because this is an irreversible step. And it can be categorized into ischemic, like a heart attack here, or it can be non-ischemic. And we found that focal fibrosis was present in over half of the cohort. But from tissue biopsies, we actually know that the majority of patients seem to have diffuse fibrosis. And diffuse fibrosis is a step before irreversible scar formation. So we analysed that. So these are MOLI images. These are pre-contrast and post-contrast images, where within each pixel is encoded information about the extracellular space. And we found that extracellular volume, or index extracellular volume, which is a new metric, was significantly elevated in HFpEF compared to controls. And for the first time, we've shown that actually both of these measures independently predict prognosis in HFpEF. We then moved on and looked at the role of the left atrium. Left atrial dysfunction, there is a priori that left atrial dysfunction predicts the development of heart failure, and then certainly in HFrEF is associated with adverse outcomes. So we assessed this in our cohort because we hypothesized the same might be true. We measured left atrial function by using the biplane method. So it's a bit like your left ventricular ejection fraction. We could measure left atrial ejection fraction. And left atrial ejection fraction was markedly lower in HFpEF compared to control. And that was irrespective of whether you had atrial fibrillation or you were in sinus rhythm alone. And we noted a very interesting relationship between left atrial volumes and left atrial ejection fraction. So the bottom of the spectrum, even if your left atrial size was normal, we observed left atrial dysfunction was present in about half of these cases. And towards the opposite end of the spectrum, we noticed that as left atrial size increased, contractile reserve becomes exhausted, so your left atrial ejection fraction dropped exponentially. A bit like Starling's law that affects the left ventricle. And irrespective of whether the entire cohort was assessed or just those in sinus rhythm alone, having a lower left atrial ejection fraction was associated with adverse outcomes. And for the first time with cardiac MRI, we showed it was actually an independent predictor of outcomes along with index extracellular volume. We then asked our next question, which was, well, actually, does technique matter? And this is current work that's been evaluated for publication. So we looked at both the short axis method as well as the biplane method. And both biplane or short axis LAEF had a good degree of agreement. And irrespective of what technique you use, the lower the left atrial ejection fraction, the worse the outcomes. We then moved on to look at the role of the right ventricle. And there is prior echocardiographic data which showed a wide range of prevalence of right ventricular systolic dysfunction, ranging from 4 to 44%. But we use the gold standard in our cohort. We found that actually with cardiac MRI, right ventricular dysfunction was present in a fifth of our cohort. And again, if it was present, it was associated with worse outcomes. Finally, we compared HFpEF with HFrEF as well as controls. And we noted key structural and functional disturbances, not just confined to the left ventricle. So in the left ventricle, we noted HFpEF had concentric remodeling. So what you have is you have increased wall thickening, but a small left ventricular cavity, whereas HFrEF had adverse remodeling, so you had eccentric remodeling, where the left ventricular mass is increased, but the cavity size also increased. Now, I mentioned previously the focal and diffuse fibrosis was greater in HFpEF, and that's true compared to controls, but we noted it was less so compared to HFrEF. And then we saw similar changes in the right ventricle as well as left atrium regarding function. We then looked at outcomes between HFrEF and HFpEF, and certainly HFpEF is associated with adverse outcomes, but outcomes are better compared to HFrEF. Now ultimately the question is, why am I talking to you about this? I'm talking to you because there's emerging data that relative to HFrEF, the prevalence of HFpEF is on the rise. So as soon as clinicians, this is the type of heart failure we're going to be seeing in the next couple of years. And there's no proven treatments. So at the beginning of my talk, I said to you there was a lot of doubt about HFpEF. But hopefully, my research, I took a bit of a risk coming back to Leicester with this slide. Hopefully my research has shown that you're now believers. Okay? And you believe that HFpEF truly does exist as a distinct clinical entity, separate from HFrEF, as well as age and sex match controls. Cardiac MRI in this setting could be extremely useful in subcategorizing these patients into different clinical phenotypes as well as pathophysiological phenotypes, enabling targeted treatment as we move towards an era of precision medicine. And cardiac MRI also helps improve risk stratification in these patients. These are a summary of my research outputs and achievements for my PhD. I would like to finish by thanking all these individuals. There are far too many to mention. It's nice to see a couple of my supervisors here. But none of this would have been possible without the support of my family. So thank you.
Thank you. So we've got time for a couple of quick questions. If anybody wants to ask some questions, don't be shy.
I'm more than happy without questions. I've got a 3-hour drive back to the world to look forward to.
Some questions from the audience?
Have you won the title yet?
Pardon?
The league title, is it yours?
Or, any Liverpool supporter would not say yes until we've won it, so I'm a bit anxious.
So in the title that you didn't want us to talk about, that you put up yourself anyway, what the F?
Yeah.
So you can now, so you've convinced us that HFpEF exists, you've convinced us that you can measure it, and then you kind of said that this is the heart failure that we'll be seeing in the future for which there's no treatment. So I can't believe that there's no treatment. So do you want to, can we press you and say, how would you treat a patient?
Yeah, so there's lots of current clinical trials being evaluated. So in terms of the mechanisms that I've spoken about, in terms of diffuse fibrosis, with animal models actually assessed with MRI, there is some evidence that you can regress that diffuse fibrosis. That hasn't translated to human studies yet. There is a study that has just finished where the CI, the chief investigator, was in Manchester, looking at fibrosis that you would normally get in the lungs, but also the same process happens in the heart, and they're looking at pirfenidone, and the results of that should be coming out soon. With regard to other targets, the left atrium, there was a study called Reduce LAP study, and what that includes is a procedure where you puncture the groin and pass a catheter to the heart, and you create a shunt, a hole in the heart between the atria, so that pressure on the left side of the heart that's too high, some of that blood shunts to the right side. And the results for 18 months are that it improves exercise performance. The danger with that is ultimately it may not reduce mortality, but eventually, if the blood's shunting across to the right side of the heart starts getting more and more stretched. Okay. So those are already therapeutic targets. And there's lots of interest in I didn't put up one of the studies that has been shown to help improve mortality in HFrEF, which is this interest in patients that are diabetic or not, but it's called SGLT2 inhibitors. And that's kind of potentially revolutionising care. But that trial is currently ongoing as well in HFpEF.
So for those of us who are heading towards the age category where this is going to be so we shouldn't worry too much. Any other questions from the audience? Okay, now we've got some questions. Okay.
How important could lifestyle change be in these HFpEF patients? Is there better prospects for that than there is with the HFrEF?
You can just use any F, that's fine.
All right, F Liverpool F.
That's fine. So again, there's data emerging that lifestyle measures, such as, for example, majority of my patients, I deliberately haven't bored anyone with the details, okay? But the majority of my patients had elevated BMI, they were obese. So clearly, losing weight will help improve your symptoms. Whether that translates to mortality reduction, you need to do a prospective study into that. And likewise, diabetes, that's what I've got to say on that.
So you mentioned in the first slide there's lots of people naming HFpEF in different ways. With HFrEF, the reduced ejection fraction characterizes the name. So my question is, do you think HFpEF could be renamed to something more appropriate?
Well, I'm going to make it even trickier because the latest guidelines potentially might include HFsNEF, okay? so there is a theory. So when I showed you that little diagram showing the trimodal pattern of ejection fraction, there's an extra bit at the end So there's patients who've got heart failure symptoms who've got supranormal ejection fraction. Okay? That's what's happening.
Any more Fs? Any more questions? All right. Thanks very much. So we've got a certificate for you. I think you already had a massive check.
It's gone to the children for the prams and all these
Sciences,
things.
so I think it's drinks on you for everybody. This is a certificate from the College of Life. So can we have a shameless photograph for that concludes the festivities on time. There's some fruits and fantastic food from the University of Leicester outside. Please feel free to enjoy, and I'm sure the speakers are going to be hanging around for a little bit, and they'll be happy to take any extra questions from you. So thanks very much for your attendance. It's great to see 70 people here. Please go and have a drink outside.